Assalamu alaikum. My name is Muzajabeen, EP 1770109. The topic of my presentation is adverse effects of chemotherapy and targeted agents. Along with my group member, we have divided different subtopics, and my subtopic is common in acute toxicity. What is common in acute toxicity? Chemotherapy agents are toxic to cancer cells and also to various host tissues and organs. The adverse effects of chemotherapy can be classified as common in acute toxicity, specific organ toxicities, long-term complications. The further two toxicity will be discussed by my class fellows. Okay, so common and acute toxicities generally include adverse effects that occur as a result of inhibition of host cells division. Tissues may susceptible to chemotherapy include tissues with renewable cell population such as lymphoid tissues, bone marrow, epithelium of the GI tract and skin. Some other common and acute toxicities is hematologic toxicities, gastrointestinal toxicities, dermatologic toxicities. The picture which I have shared is like exposure, and from the environment when we inhale something like inhale and it is exposed to the skin, so it can cause toxic effect by after the absorption, metabolism, distribution, elimination, then it goes to organ level like CNS, lung, reproductive system, etc., to then to the cellular level, then to the molecular level. Now, as a clinical pharmacist, what is our role? Clinical should be aware of specific factors such as the target of disease, concomitant illness, concurrent medications, which could cause signs or symptoms that mimic the adverse effect associated with chemotherapy. In addition, most patients with cancer commonly receive many other medications, including antibiotics, analgesics, that can cause additional adverse effect or interact with chemotherapy. Therefore, the clinician needs to be aware of the presentation, management, prevention of the most common toxicities that could affect patients receiving chemotherapy. Now, what is hematologic toxicity? Effect of chemotherapy in bone marrow. Bone marrow is spongy tissue inside some of the larger bones. It makes most of the body's blood cells. Bone marrow suppression is when fewer blood cells are made in the marrow. It's a common side effect of some strong medications such as chemotherapy. The picture which I have shared is like bone marrow, which is the body make white blood cell, red blood cell, platelets. Now, what is bone marrow suppression? It can cause anemia, decrease in red blood cells, neutropenia, decrease in neutrophils, thrombocytopenia, decrease in platelets, pancytopenia, decrease in all types of blood cells. So, what can cause bone marrow suppression? Chemotherapy medicine make it harder for the bone marrow to make blood cells the way it normally does. Nearly all chemotherapy medicine cause a drop in blood cell counts. So the drop in blood cell count, depending on which medicines are used, radiation therapy, cancer treatment can also sometimes suppress bone marrow. Okay. Now, second is gastrointestinal toxicities, dermatologic toxicity, GI toxicity. This will be discussed by my class fellow. The small thing which I would like to share is to know what is GI toxicities. They are dose limiting of many anti-cancer therapy can cause treatment delays or cessation and be life-threatening. So it can cause diarrhea, nausea, vomiting, stomatitis, colitis, these are the adverse effects caused by many anti-cancer therapies. And what is dermatologic toxicity? Dermatologic toxicity associated with chemotherapy include alopecia, hypersensitivity reaction, extravasations, and hyperpigmentation. It can cause nail changes. Dry skin, blistering occur when chemotherapy agent reduce or inhibit mitosis in the epidermis and nail matrix. Other chemotherapy agents can cause various skin reactions when they interact with ultraviolet light or radiation, as it is shown in the picture. As you can see, different toxicity like alopecia, fissure, xerosis, rash, pruritus, fungal, nail fungal. Okay. Next is The case studies, myelosuppression. GT, a 45-year-old 59 kg man with no significant past medical history, present to the university hospital with complaint of cough and shortness of breath. Chest radiograph reveals a lesion in the right upper lobe. Bronchoscopy, washing, and cytologic examination are positive for small cell lung cancer. But a workup for metastasis is negative. GT is diagnosed with limited SCLC. His physicians plan to initiate radiation therapy to the right upper lobe with concurrent chemotherapy to include carboplatin, uh, topotecan, and etoposide. Discuss with GT the toxicity that may be accepted to occur with this regimen. The different doses are given. Okay, what effects on the bone marrow can be anticipated and how might they clinically appear in GT? What factors can influence the incidence and severity of these adverse effects? When can GT expect the effects to occur? So I will discuss this case study. Soap note. The subject GT, a 45-year-old 59 kg man, present to University Hospital with complaint of cough and shortness of breath, and there is no medical history, past medical history. There is no. And the diagnostic data shows the chest radiograph reveals a lesion in the right upper lobe. There was a lesion, okay. And bronchoscopy, washing, and cytologic examination are positive for small cell lung cancer. So it can be so we can thought that he has small cell lung cancer, but there is no workup for metastasis. It is negative. Okay, it is not spread in other parts of the body. Object: physicians plan to initiate radiation therapy to the right upper lobe with concurrent chemotherapy to include carboplatin targeted to an area under the concentration time curve of 5 mg per ml per minute on day 1, topotecan 0.5 mg per meter square daily on day 1 through 3, and etoposide 100 mg per meter square per daily orally on day 4 through 6. Now, what the assessment we could see, with the help of the provided information, several toxicities are commonly associated with carboplatin and topotecan and etoposide. So, the most predictable toxicity associated with this regimen is myelosuppression. Okay, as I have told you, what is myelosuppression? This chemotherapy regimen can significantly affect any cell line, including RBC, neutrophil, platelets, and cytopenias can cause significant morbidity and mortality. Okay, so host factors that specifically may affect the cellularity of the bone marrow compartment also influence the degree of cytopenia. They include the following, like patient's age, what is patient's age, bone marrow reserve, the degree of compromise from previous chemotherapy, radiation therapy, or both, the ability of the liver or kidney to metabolize and excrete the compound administered. Okay, what management we could take? Management of SCLC is complicated by aggressiveness, frequent substantial comorbidities we have to check, caused by smoking, impaired performance status, which make it challenging to enroll patients with SCLC to appropriate clinical trials. As you can see, small cell lung cancer, it is divided into limited stage and extensive stage. So, limited stage is like it is uh, it is limited to the lung specifically, like T1 to T3 surgical candidate, no concurrent chemo, radiation, surgery, adjuvant chemotherapy, then in prophylactic cranial irradiation. But extensive stage is dangerous, like it spreads to both of the lung. It can affect both lungs. Systemic combination chemotherapy we give, and then surveillance with body and brain imaging or prophylactic cranial irradiation, thoracic radiation. Okay. Now, what our plan for this treatment? Like our first line treatment, the combination of etoposide with a platinum-based agent is still the standard of care for ES-SCLC, like extensive stage small cell lung cancer. Unfortunately, responses are often short-lived, and SCLC universally become resistant to subsequent chemotherapy. Like it is very difficult for us to treat. Okay, So second line and beyond, topotecan as a single agent is the only regimen that has been proved prolonged survival of patients with relapsed SCLC compared with best supportive care. Topotecan is currently the most widely used chemotherapy regimen for relapsed or refractory SCLC. However, topotecan is not effective in patients with SCLC who have relapsed within 3 months after the end of the previous platinum doublet chemotherapy. Okay, the plan is this: we can give topotecan. So, in the last, I would like to tell you there is no sure way to prevent lung cancer, but you can reduce your risk if you don't smoke. If you have never smoked, don't start. Stop smoking now. Avoid secondhand smoke. Test your home for radon. Avoid carcinogens at work. Eat a diet full of fruits and vegetables. Exercise most days of the week. Thank you so much. I hope you like my presentation.